Well, I'm going to go ahead and start with an introduction. Before I introduce our speaker for today, I want to welcome all of you to our Department of Geriatric Medicine Grand Rounds, and I have a few announcements to make. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabson Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find evaluations by following the link in the chat at the end of this talk or at any time on our website or email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. It's my great pleasure to welcome our speaker for today, Dr. Noam Grysman. Dr. Grysman received his medical degree from Tel Aviv University, Sackler Faculty of Medicine, Israel. He attended both psychiatry residency and geriatric psychiatry fellowship at St. Louis University, Department of Psychiatry and Behavioral Neuroscience. He's board certified in psychiatry and board eligible in geriatric psychiatry. His clinical and research interests include geriatric psychiatry, dementia, behavior interventions in the treatment of dementia, psychopharmacology, and decreasing polypharmacy. Please join me in welcoming Dr. Noam Grysman.
Thank you. Thank you so much for that lovely introduction. So I hope everyone can hear me well. If not, please shout out during the presentation. I'll be happy to do what I can to make this a little bit easier and definitely audible. I'm here to talk today about cases that is a little bit different, I think, in Hawaii, but I'm hoping to give you guys more of an education that will be well-rounded in no matter what state you go to. And I'm here to talk about challenging cases, specifically psychogeriatric cases in long-term care. So firstly, I have no relevant financial relationships to disclose. I always joke at this part, I'd love to have them though, it's always good to supplement your income, but at least as of this time, I'm not blessed enough to say I have anything to disclose from a financial perspective. That being said, I do intend to discuss off-label investigative use of commercial products, specifically antipsychotics and antidepressants, as well as other medications to be used in the treatment of behavioral and psychological symptoms of dementia, as well as in the treatment of delirium. So that is definitely something I want to make sure that you're aware of. With respect to educational objectives, we're going to hopefully have some case vignettes here. And one of my goals is to have this be a more interactive discussion. I was never one who liked, frontal lectures. I know it's a lot harder now that we're on Zoom for people to really have that impetus to sort of speak up, but I will encourage you to do that at the times that I will definitely note. And the goal is here, we're going to use some clinical cases to understand the differential diagnosis and evaluation of various cognitive, affective, and behavioral disorders, specifically with psychogeriatric patients in long-term care, to figure out what are the appropriate pharmacologic or non-pharmacologic treatment options, and realize and recognize what role the psychiatrist can play in long-term care, and especially in the management of behavioral disturbances in older patients. So the first couple slides I have, I think are, I would say, less applicable to Hawaii, or maybe differently applicable to Hawaii, which is what is long-term care. And the idea is that there's some, I guess the best to say is differently applicable, because long-term care can include assistance with your activities of daily living and health maintenance tasks, but where you receive them is a little bit different. So you can have community-based, which are adult services for the day, home-based, such as a home health agency, institutions such as nursing home or skilled nursing facilities, including memory care, and other residential settings. And I think that's where we have a little bit of a difference in Hawaii. So assisted living, similar residential care communities, but we also have foster homes here, which have a different sort of level and a different sort of engagement. In 2016, we noted that 1.4 million Americans were admitted to nursing homes. Of those, about a little under half were a short-term stay, a little bit over half were a long-term stay. 83.5% of residents were above 65. And of those, 47.8% suffered from dementia, more often the long-term stay residents. And I want to make it clear that when we say dementia, it's not including mild cognitive impairment. So that isn't to say that, 47.8% of residents suffered from dementia, therefore over 50% of residents are cognitively intact. Rather, 47.8% suffered from dementia, and then of the remaining ones, we don't know, we can't necessarily, the data doesn't have whether or not they were cognitively intact or suffering from mild cognitive impairment, which I've heard, at least anecdotally and colloquially, people are saying it's harder and harder to find fully cognitively intact patients in nursing homes. And that's sort of the environment that we're seeing. Now, of 4 out of 5 long-term care residents at any point in time would likely benefit from psychiatric treatment. And the most common reasons that were consulted are, primarily behavioral and psychological symptoms of dementia, especially agitation and psychosis, then depression, then anxiety and sleep disorders, delirium, personality disorders, and end-of-life or palliative care consultations. Now, I know I breezed through that pretty quickly, but that's sort of the point because I really want to get to what I view the meat of our presentation, and these are the cases. So with everything that I've just said in mind, we're going to use, just as a note here, all the people that are mentioned in my slides. None of these patients are real. A lot are based off of experiences I had where I gathered certain conditions that I had experienced or I experienced treating, and sort of made a bit of a combined form. So there is no patient information involved in these studies. Now, our first case is of a lovely lady named Mrs. Annie. She's an 83-year-old female who is a short-term residential stay at the Sunshine Nursing Home. She's recently admitted after a stay at an outside hospital, and we were consulted because of dementia and anxiety. And this is where we get into the audience participation. What does it mean, this consult? Well, how would you approach this scenario? And I would love to have, I know we have some amazing geriatric medicine fellows here. Anyone who's welcome, though, to speak up and give what they think would be something you'd want to take in mind when you are approaching this.
Well, no, I'm not a fellow, but until one of our fellows kicks in, one of the things I'd like to know is her baseline.
Exactly. That is a really, really good question to ask. And I will say, just as something to keep in mind for the rest of this presentation, as psychiatrists, we are taught to how to handle uncomfortable silences. So I don't want to play a waiting game with you guys, but I can. That's one of the most important things is that when you get called from an outside hospital and you're consulted, you want to figure out what the baseline of the patient is. And that is absolutely, something we want to hear. What are some other questions we want to hear about? And here just we'll say, imagine you're being called either by the nursing staff or by, the doctor that is consulting your service. So they're saying dementia and anxiety. What are you going to ask them? I'm seeing in the comments. So firstly, thank you, Haijing. Is she on any medication that can make her anxious? And then from Dr. Monaco, we're seeing history, collateral information. And again from Jing, are there any precipitating events? Patricia Lee, description of the anxiety behavior explains what's happening. What are the specific behaviors from Lauren as well? Any recent changes? These are all great, 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 great questions I'm hearing. So what is the baseline level of functioning? What is her history? And what are her behaviors? That is absolutely correct. When we're called, we always get called for, like I said, dementia and anxiety. What do you mean by that? Please explain what is going on. So going on to that idea, The records are limited because, again, we all know how we love an outside hospital, but the patient was found down and dehydrated in her home for an unspecified length of time. There was concern for a spinal fracture. The CT head showed, quote, and I love this because if I had a drinking game, every time I found this result on a CT head, I'd be very drunk. Or I guess said if I had a nickel, would be probably a more appropriate thing in here. But no acute intracranial process, small vessel ischemic disease consistent with aging. I'm not sure how many times you guys read that, but I read that. Last time I read that was this morning. Current medications are amlodipine, oxybutynin, hydrochlorothiazide. She was started on tramadol in the hospital for pain, as well as Haldol 5 milligrams Q6 PRN for agitation. In the nursing home, when we're asking what are her specific behaviors, she's intermittently anxious, saying she does not know where she is and she needs to find someone named Jeff. And then on your examination, the patient is sleeping on her sofa chair and difficult to engage. So what are we thinking? What after this, we get this information. What are the thoughts that are going through your head in terms of evaluation? What do you want to test? What are your thoughts towards diagnosis? What are your thoughts towards possible causes? Polypharmacy, and can we do something else for pain regimen? These are great thoughts. So before we get there to the can we do something else for pain, which I agree with, but polypharmacy is something definitely that's thought about here. But also a lot of this stuff, we got a history of what brought her here, but at no point anybody wrote a message here that in our records that we can find dementia. So we have to figure out where we got that consult, because very often when we're given consults, and it's not necessarily of anybody's fault, but we'll get a consult, they'll put a diagnosis in because you can't order a consult without linking a diagnosis and people will just throw it in. But then based off of that, you're going to have somebody slapped with a diagnosis that they may not have had. So our lovely Mrs. Annie, who's by all means an 83-year-old sweet female and is clearly, not necessarily understandable or legible here, there's no necessity to state that she actually has dementia. When you're seeing her, she's sleeping on her sofa chair. But also, she was down and dehydrated. We have one CT head scan, and it says no acute intracranial process, which also it says small vessel ischemic disease consistent with aging. This could be a sign that there is some vascular involvement, and we have to be worried about vascular dementia. This also could be absolutely nothing. In terms of other diagnoses of dementia, MRI or any head imaging findings are often non-specific in early stages. Some, you can definitely have something showing that evidence of frontotemporal dementia, but a lack of that evidence does not indicate you don't have it. And same with Alzheimer's. We know that there's, in general, shrinking of the cerebrum and there's enlargement of the ventricles, but in earlier stages, it could be negligible. So we also know that at the time of the consult for the CT head, they weren't looking for anything other than acute issues. So they may not be looking in depth to see, oh, well, the exact small ages, changing in brain structure. So if there was something small that would have been found, it may have been overlooked. The other thing is that we're seeing here is then she's been dehydrated and she's in pain. This is generally our recipe for delirium, right? And so if anyone knows that, as psychiatry, we love saying this, delirium is waxing and waning level of consciousness and an inability to sustain attention. So having someone who's intermittently anxious, doesn't know where she is, and she's needing to find someone named Jeff, and then she's difficult to engage when you see her and she doesn't seem anxious at all, this already reports to delirium. Throw in the fact that we've got dehydration. That's another thing to be concerned about. And then in terms of what you'd want to go for from there is akathisia. Haldol dose is very high. I'm hearing from Patricia. I think that's absolutely an option, but we don't know actually when she got on the Haldol and how much of it she received. So when she's on the Q6 PRN, was that from the hospital that she was in, or did it lead to her fall to begin with? It's a great question. If you had someone who is down and dehydrated in her house for an unspecified length of time, maybe the diuretics at this moment, could be making things a little bit worse. She's on an opioid medication, which is deliriogenic. We've got the idea that her HCTZ could be potassium wasting, and then we're giving her Haldol as well. So we want to be worried that, yes, there may be prolongation of the QT. We know that there could also be, if you're dehydrated and you're down, there may be a UTI. And as one of the most common cause of delirium in elderly ladies is a UTI. So here, one of the things that I'd want to order is a UA, because there's no mention here that they actually have a UA. And that's one of the things that's also, I always tell people about this, is something that was taught to me. I'm never a big fan of shotgunning tests, and also another issue that you got to have in a nursing home is, or wherever your patient is located, actually, much more importantly, less important in nursing home, is what tests can you actually do? So out in our foster homes, elsewhere, what kind of tests can we run to say, well, this person needs another CT? It's not something they're going to get at their foster home. But your analysis is very often attainable. So it is something to look into as if it's an option for us to get. I would definitely want to get an EKG between the potassium wasting diuretic and person being on Haldol, because we could be worried that we're having some QT prolongation leading to TDP. And then the last thing is, we had the CT when she was found down, but we don't know how long she was down for. Is it time to consider a repeat CT for a slow progressing subdural hemorrhage? So like I said, these are cases that aren't real people and they don't necessarily have real answers. These are things that I want to sort of stimulate to have people think about the various implications of what to do. So as much as people aren't necessarily going to be happy with this answer, we don't actually have an answer for this case. We're going to move to the next one. So our next case is someone by the name of, oh, I'm seeing something from Jennifer Nakamatsu. And I would, if possible, Jennifer, do you mind speaking up? Just because I'm not sure if me reading it out is always best.
Hi, sorry, I'm here with Sherry Kogan too. Yeah.
Hi.
We totally agree that sometimes, those UTIs are stealthy, but oftentimes we see that they just have asymptomatic bacteria like all the time. Yes. In the institutions, like when they just kind of have pulled and checked before and done these studies. And so sometimes people like reach for that, but then they treat, overly treat, I think, sometimes.
Yeah, that seems to be the checking your UA is a very reflexive thing that happens at Queens a lot when there's no actual urinary specific symptoms. So we have the opposite problem here, that everybody gets treated for a UTI and there's never any looking beyond a dirty urine for the cause.
And to that, I wholeheartedly agree with you. And I want to make it very clear that in these instances where we're recommending it, it's, we don't know, we have symptoms, but we don't know to what they're related. And that's a very good point, that you have to be dangerous about over-treating UTI. And honestly, I have nothing but kudos to Dr. Kogan for helping me with that as well, in showing we never want to over-treat. But when it's someone who's showing an acute change in their behavioral status, and then we also have the concern about, especially in those with dementia, they have a decreased ability to communicate, and also potential decreased sensation to pain, as well as being an unreliable historian. So that's where we want to really start digging a little bit deeper. And that's where the UA comes in handy, and also having a very good geriatric medicine specialist on hand to speak to, because we don't want to just empirically treat everything. For case number 2 with Mr. Tom, this is something that we also frequently come across. So we get a call at 2 a.m. from a nursing home memory care unit saying that the patient that you're seeing, an 85-year-old gentleman by the name of Mr. Tom, who has moderate to severe Alzheimer's disease, is, quote, out of control, screaming, agitated, and hit his roommate and scratched his nurse. What are you going to do right now, right this second? And we've got 4 potential options. I'm seeing someone write number 3. Anybody want to speak up? All right, we have 2 votes in for 3 right now. So let's talk about that. Giving olanzapine 2.5 milligram PO versus IM. Well, olanzapine intramuscular does reach peak plasma level about 15 to 45 minutes after its administration, and its serum concentration is about 4 to 5 times higher than its oral dose. Whereas trazodone would take about 2 hours to reach peak concentration, and something else like Seroquel would take about 30 minutes to 3 hours to peak concentration. Now, specifically in this situation, when you have someone that's out of control and swinging, and it's 2 a.m. and you don't know what to do, I agree, we give the PRN. This person, we have to be worried about staff safety, patient safety, family safety, and we have to control a dangerous behavior. There are many causes that could be going on here. Like I said, like I said in the previously, there's always delirium. This could be a new behavior in his dementia, though he was previously stable for some time. Maybe there's pain going on and he doesn't know what's going on, but we're not sure. And it's 2 a.m. We're not making our way down to the nursing home right now to do a full evaluation, because even the time it would take for us to get there could increases the likelihood that there are people at risk. So at this time, we give the olanzapine and we follow up the next day. Speaking of which, the next day, you don't forget about it, you go to it, and you note that there was a new nurse on the overnight shift that night. Over the subsequent weeks, this patient continues to have intermittent, repeated episodes of agitation. Most often, these occur overnight. The family's starting to get worried. They're afraid that Tom is going to be kicked out of the nursing home because he has this agitated behavior, which is very frequently the case. If a patient becomes too agitated, they're shown the door. So what would be your next step? And I'm going to say, let's not have people posting on. Let's have someone speak up, if possible.
I don't know. I would really try to explore the non-pharmacologic approach. I think approach is huge and it's the quickest solution. And, you know, we really need to find out a little bit more. Maybe there's some trauma in the past. Maybe he's got PTSD. Maybe, you know, we need to approach him more gently. You know, maybe there's this, you know, other strategies that have not yet been consistently tried.
I agree wholeheartedly. So what kind of approach would you take then?
Education with the nurse.
Okay.
Whoever's on that night, I guess, and to make sure you're not doing stuff that will exacerbate the problem. Right.
So one of the things we have to keep in mind about nursing homes, and this is very difficult, and this is where I do apologize for, I'm not sure how it translates to Hawaii, but again, nursing homes and other care homes, they're often stretched very thin in terms of staffing. So what you'll have is nurses who are caring for tens of patients during their shift. I remember I had a friend, this is anecdotal, I want to make that disclosure. This is anecdotal, this is in a different state. And in this different state, there were no restrictions for how many patients could be assigned to a nurse in a nursing home. So I had a friend who said between her and one other nurse, they were seeing 40 patients over the course of an 8-hour shift, 20 of which needed insulin administration, which, as you know, if you're not aware, requires 2 nurses to be present for that to make sure the appropriate dose is measured out. The entire system itself takes about 4 to 5 minutes to administer to one patient. So an 8-hour shift, 40 patients, 20 of which need insulin twice during the shift. You do the basic math on that on how many minutes they're spending just on the insulin, not how are you doing other assessments, answering calls, doing intake, speaking with family, addressing a fall, patient becoming agitated. It's a systems-based issue where you're having, they're not necessarily able to directly answer a patient need. Based on that, documentation may not be perfect. And also burnout is high. So you're noting that there was a nurse on that overnight shift, and then we know that there's repeated episodes of agitation, most often overnight. But this patient who's got moderate to severe Alzheimer's is not a great historian. They're not able to tell you exactly what happened. So what happens is we at this point have to become, in a sense, detectives. we have to start asking questions specifically, as you mentioned, and I apologize if I'm not pronouncing your name, but Aida, I appreciate what are the non-pharmacological approaches? And now we've got time to do that. You know, it's 2 a.m. It was the first time we give the olanzapine. Now we have to start actually looking critically. And first of all, is it always this nurse that's on overnight when this patient's agitated? When you mentioned PTSD, that's very, very good question. I had the opportunity of spending some time, you know, many years back before I was a doctor, at Baycrest, which is a memory care nursing home, research center, and hospital for the elderly, and it's located in Toronto. And this is a Jewish nursing home that has a history of holding a lot of Holocaust survivors as its residents. And they were actually at that time known to be leaders in what they could do in terms of behavioral interventions to reduce stress from occurring, to stop these behavioral outbursts before they happened. So one thing that I specifically remember was that when we were there, and I wasn't even working with patients, but every single employee and volunteer had to go through this training, whether or not they would be with patients, residents, they would have to go through the training of how to approach patients, specifically keeping in mind Holocaust survivors. And one thing was, you are never allowed to ask a resident to line up at the cafeteria for food. They were not allowed to line up. And this was very, very important because that's how it used to be done in the concentration camps. I was also specifically told that anytime that it came time to shower patients or bathe patients, it was a very, very specific process that was studied, and it wasn't just taken at face value. I think that we were recently, I didn't get a chance to attend, but I know Teepa Snow was recently presented here, and she talks similar to making sure the environment and the context is appropriate. One thing to say with the trauma, there's also another instance. One of my grandfathers had at a point where he would be yelling, is a very similar case actually that happened here, that he would yell that and threaten one of the nurses. And what happened was, you know, the nursing home was saying he's going to have to be switched to another more acute unit. And one thing I credit my father for doing at this time was he went and traveled and stayed with my grandfather overnight, because nursing staff, again, like I said, they're very overwhelmed. The nursing staff is incredibly overwhelmed. So they're not about to spend the entire 3 hours sitting with the patient to see what makes him upset, or a resident, again, depending on how we're discussing it. And they don't have the resources, and they shouldn't be expected to. But however, if you can get family members over there, my father went there overnight, and he noticed that he was accusing this one person, this one nursing staff member, of being a lawyer that he knew in the past. So he's yelling out the lawyer's name, but to anyone else, it's sounding like gibberish, because you just hear somebody yelling, "Poolin, Poolin, Poolin, where's my money, you son of a bitch?" You know? And what happened is that there was an incident that he had with this person many decades ago, and this nurse apparently looked exactly like him. They moved the nurse to a different unit still, and all of a sudden, all the outbursts stopped. So that's one instance. Another instance I've heard is I've had cases where I've had a colleague once told me that there was a patient that started pretty much punching everybody that went and opened the fridge in the day room of this nursing home, and they had consulted again for agitation and violent behavior, and they noticed that this sweet little old lady would never hit anybody. And she never had in the past, but now when someone goes to the fridge, she punches them. And what the consulting psychiatrist did here is he walked towards the fridge, he looked at her and said, "Do you mind if I take something from the fridge?" And she said, "No, go ahead." He opens the fridge, takes whatever he wants, and walks away. This person did have a progression of their dementia to now they thought the fridge was their own, and they were very upset when anyone tried to steal their food. However, simply asking her, "Do you mind if I take some of your food?" she'd be fine with it. So here's where you get into the discussion of what behavioral intervention can we do? Is it appropriate that we impose this limitation on everyone when it's not this lady's fridge? Is it appropriate for us to ask, you know, a nurse to work on a different floor? And it's really a case-by-case basis, and it should be a communal discussion. It should be a discussion that we're going to have. But we always have to make sure that we're very careful in how we discuss this with the nursing staff and with the staff at the nursing home. Because, like I said, it's not that they're not trying, and it's not that they're, when you think they can be very burnt out and being exposed to a lot of difficult scenarios, not enough funding, not enough structural support. Often when they call the doctor, sometimes they just want medication. I mean, we're going to touch a little bit of that in the next case, but it's not out of a fault of their own, but as of an issue of structural problems that may have been going on far longer than we've been consulting at this nursing home. I'm going to go to the next slide to our next case. So our case number 3, we have Miss Eve, okay? And Miss Eve is an 88-year-old lady in the special care unit of the nursing home. She has advanced Alzheimer's disease with the slums of 4 and has been stable behaviorally, but now she's episodically agitated, wandering with an unsteady gait, hollering, and striking out at the staff during cares trying to do activities of daily living. So, what are the diagnostic possibilities? What is the most important part of the evaluation? Why may she be striking out during care? And what are the good drugs or bad drugs that we could use for this 88-year-old lady? So things as we've clearly discussed with all of our other cases, and just want to remember, we want to look at acute behavioral change in a patient. So why now? If this has been a lady that's been stably with the slums of 4, but always happy until now, what are the triggers? What could be something that's causing a change now? In general, with severe Alzheimer's disease, as they age, there's a period of increased agitation, and then that agitation behavioral outbursts decrease, sadly, with the level of functioning decreasing. I once spoke with a family member of someone with Alzheimer's disease, and when I was doing surveys on the progression of Alzheimer's disease, and every time I asked a question, he said, "I'm going to cut you right off. My mother's become a potato with arms and legs." That was how he described it. It was very sad, but he was saying that this was the progression of Alzheimer's, that she became generally less and less motivated, less and less active. So even if it was the delusions themselves went down, but the communication went down. And anytime I ask her, does she strike out at other staff? Goes, nope, she's a potato. Potatoes don't hit people. But that was literally how he described it to me. So one of the things we want to ask is, why now? What's causing it? Are there environmental triggers, such as a noisy roommate? How are the staff approaching her that she maybe can't see or hear them approaching her, and then all of a sudden strikes out as she's surprised? And we'd want to look at potential physiological triggers for agitation. For example, many causes of delirium, such as infections or drugs, new onset psychosis, or is she having severe pain? So with Miss Eve, let's take a look. The last time that you were consulted to see Miss Eve, as we know in nursing homes, sometimes when patients are doing well, we don't always go and see them, right? Which is fine. But the last time you saw her was 1 year ago. And at that point, she was stable on her regimen of a rivastigmine patch, sertraline and trazodone, 25 milligrams 3 times a day as needed for agitation. 4 months ago, she was admitted to a hospital for 2 days for a fall. Since discharge, her regimen is now donepezil 5 milligrams at night. She's also on quetiapine, 50 milligrams twice a day as needed for agitation. And rivastigmine, sertraline, and trazodone have all been discontinued. Anyone want to have a comment as to why this happened and what to think about this?
Hi, Dr. Grysman. This is
Hi.
Colby. I'm one of the geriatric faculty.
Thank you.
I would ask, was there a reason why she was on antidepressants? And did she have symptoms of depression before all of these medications were started? Or were they started sequentially?
That's all great question. The other question is, why has her regimen changed? So sadly, I think what we all know, I think now that if or a lot of us should know, or not should know, a lot of us have experienced in medical care, is a lack of continuity of care is very dangerous and sadly very frequent. I have seen many a patient go from a nursing home to an outside hospital or an inside hospital for that matter. And if there's not a proper sign off, or sometimes even if there is a proper sign off of what a patient's medication regimen is, it does not always translate, and the hospital will resume whatever regimen the patient was on whenever they were on their most recent admission. So what happens is you can send this patient out to another hospital and they'll say she was previously stable on X, Y, and Z when she was here 5 years ago. They'll resume that. They'll just assume it was the same. The other ones was also, the other reason is sometimes they'll ask, have there been any medication changes? And the nursing home will respond, no, there hasn't been medication change in a year. So great, so we'll put her on the same regimen we had listed 2 years ago. But that isn't necessarily the same thing. So that's one thing that happens. We want to be careful also, maybe there was a deprescribing going on, right? I often come in and I love doing deprescription. It's one of the most important things that we do. And I think geriatric medicine would agree. But we always make sure that there are some medications that are helpful. So we think about this sertraline. What was it used for? That's a very good question. Another question to ask is, and one of the options that it can be used for off-label is behavioral and psychological symptoms of dementia. It is frequently used for that. That being said, it is helpful and sometimes it isn't. So it could be in the best interest of deprescription, this was reduced. But if there wasn't continuity of care, if the physician that was prescribing it wasn't contacted and wasn't aware, it could be that they specifically had noticed quite a benefit with this. I, in my residency, was quite guilty of reducing what I thought were complex regimens and then just bringing it right back, because whatever it was, that was, what I call the secret sauce that helped to keep a patient stable. So obviously, if we're talking about these behaviors for agitation, one of the questions are, why are they consulting us now? Did this behavior start 4 months ago or did it start 2 days ago? And like I said, you want to look for an acute medical issue, any pain, any UTI. I know, though, we have to be careful with that. I agree. The other thing you want to check is donepezil, often when given at night, can cause side effects with sleep. So is this current regimen that she was
Noam, I'm so sorry. We suddenly don't hear you anymore.
All right, can everyone hear me?
Now we can hear you. Thank you.
All right, where did I cut off? Oh,
Less than a minute ago.
yeah. So one thing we want to be careful about, like I said, is donepezil can cause some sleeping side effects. When given at night, more often, it's less likely to help people have a good night's sleep. So we do have a concern of this could be altering her sleep cycle, which is leading to a decline in behavior. We could find out, like before, we want to see if there's any acute cause going on. Trazodone is often used in doses of 50 to 150 milligrams at night for sleep, but off-label it's also used, and that is off-label in itself, but off-label it's also used in doses of 25 milligrams, which is half of the smallest tablet, for agitation, with some positive benefits, but studies on it have been mixed. So I do want to keep that in mind. In some population as well, it can actually cause paradoxical agitation. Now, like I had mentioned before, we have the black box warning for antipsychotics. So the use of quetiapine 50 milligrams as needed, we do want to be careful about that. Not to mention that at that dose, it's primarily works as an antihistamine, which is problematic with respect to how we're going to, how this could be a possibly deliriogenic medication. So continuing with Miss Eve, you switch the donepezil to the AM dosing. You discontinue the quetiapine. You resume the trazodone 25 milligrams 3 times a day and start titrating sertraline. 4 weeks later, the nursing staff calls you back and they say the trazodone does not work. We need something stronger. So what are you going to do at this point when you hear we need something stronger and that it's not working? So I'll take the lead here. One thing you want to check, and this is actually something that I've experienced personally again, is when they say it's not working, how often are they giving this medication? I've had instances where I'm told it's not working. I was told, this patient of the past 14 days, 11 of them have been bad where he's been agitated. And I went and I checked the medication administration and found that only 3 days did they administer the trazodone. We want to say when someone says a medication isn't working, there's some assumption that the medication was given. Sometimes it's not. You also want to check to make sure that the changes that are recommended have been implemented. Unless you're putting in the direct orders, there's very often that things will get lost in a handoff or a shuffle. Even when you are writing the direct orders, if you're not putting it into the electronic prescription system versus just writing it on a paper and handing it to nursing staff, this very frequently occurs that this medication change will get lost in the shuffle. So you want to check every single thing that you recommend to make sure it's been implemented. Now, what are the options that you can do? Like we've mentioned, there's behavioral interventions. There is finding out if there's any cause, treating underlying medical illnesses of delirium. In terms of the behavioral and psychological symptoms of dementia, assuming all of those options have been exhausted, we do have the option of trazodone as needed in slow doses. Antipsychotics have been used. There's actually currently, I believe the FDA is looking over an application for the use of brexpiprazole, which is one of the newer antipsychotics, to be FDA approved for the treatment of psychosis and dementia in Alzheimer's disease specifically, and agitation in Alzheimer's disease. SSRIs are currently considered an option, though I do not believe they're FDA approved. Mood stabilizers have been used, and that again you do have to be cautious. There's a new drug out called arguably whether or not it's a new drug, but a new formulation of dexmedetomidine, which is a cheek melt version of Precedex that has been shown to be used to immediately decrease acute agitation in those with schizophrenia. However, it's not been approved yet, I believe, for Alzheimer's disease, but it is something that can be considered to look into. It is an interesting idea. Like I said, this is not FDA approved. Often used as well, you can have benzodiazepines, but they're quite deliriogenic and not something that's recommended, but they are frequently used. Acetylcholinesterase inhibitors have been used and in both the treatment of progression of symptoms, but also to help treat with behavioral symptoms with dementia. Memantine as well. Electroconvulsive therapy in more extreme cases can be used and has been used actually with quite a significant benefit in some cases. When taking this into mind, these are all options that we can use in our arsenal, but much better is deprescribing to figure out if there's a medication that is instead of trying to add on a medication to fix a problem, seeing if there's a way to reduce a medication to fix a problem is definitely the first line approach. Now, we keep in mind when people are asking you for something, quote, stronger, we have to make sure to help with our education of both the teams that we speak to and as well the families and sometimes the patients. Greater potency does not equal increased efficacy. And there are often times that when you take out, the big gun antipsychotics and they don't work, trying something smaller may actually be better. One thing that I was made aware of, I haven't had the opportunity to look at it yet, but just recently prescribed, we have the 2023 updated Beers criteria. So I know I'm preaching to the choir here when we have to be looking out for this and making sure we're taking that into account when thinking of ways to help treat an issue. And let's see if there's both looking at the medication regimen they're already on and considering a new medication to give them. You want to keep that in mind. And lastly, always check to make sure whatever changes you recommend are actually implemented prior to going on for another change. This is going to be the last case that's going to be discussed today, and this is Miss Sally. And she is a 75-year-old long-term resident of the Executive Manor Nursing Home. She has a history of Alzheimer's dementia. You have been consulted for sexually inappropriate behaviors. And this, although this is adult content, just keeping in mind, the patient was seen masturbating in hallways and hugging other residents without consent. However, she is redirectable. What are your thoughts when this happens to approach this situation?
I don't know, be interested in finding out what her social history is.
I think that's a great point. I also like to point out Monica Orsine, I believe, if I was pronouncing that correctly. What she has sexual needs and maybe misses her partner. This is a very, very good point. However, we also have to make sure that we're maintaining appropriate safety of everyone around her. But that is the exact point that I wanted to touch on. We have to talk about this. There's a discussion here. First of all, we have to check, like everyone had mentioned for all the earlier cases, this is a departure from baseline. So is the patient married? What were her previous sexual preferences? Were they more conservative or liberal? What about the other person involved? Was she hugging random people? Where was this behavior occurring? Right? So she says she's in the hallway. Was she in the hallway? Was she right outside her own room? Was she somewhere that there was somebody else? This is a lot of uncomfortable discussions to have, but they are important. So what we need to know is what is the exact behavior, even though it's a discussion to have, but we have to have what is the exact behavior and what can we do to understand the context of the situation. Ultimately, anybody showing unwanted physical touching, explicit sexual behavior in a public area is not appropriate. We have to redirect. We have to figure out what's going on. However, in patients with severe dementia, we have to check as well to see what's the accuracy of the report in the sense of, one, they're saying she's masturbating in the hallway. Is this a person who had a catheter in or something else and she was reaching out, she was uncomfortable? But more importantly, has there been any sexual abuse going on as well on the unit? We have to be careful about, is there any staff that could be taking advantage of her? And then if not, we have to figure out what's leading this behavior now and how can we help somebody feel comfortable. The right to human sexuality is a basic human right for every person. However, once you reach the nursing home, there's also the idea of making sure that you're in a safe environment. People may not know how to express themselves, their own, and reach their own physical intimacy goals, but there is a way for that to be done safely and appropriately and privately. Sometimes not. We have to figure out what the role of us as physicians, the role of nursing staff, the patients and the families regarding aging and sexuality are. We have to make sure that we're protecting dementia patients from being taken advantage of sexually. So even when patients do have the right to their own sexuality, do they have the capacity for consent? And this is a topic that is very complex and is not discussed enough in our current literature. So we do not actually have a good answer here in terms of standards of care and standard practices. There is a discussion from 2011 in the UK, which includes a guide to dementia, sexuality, and intimacy as sexual behavior in care homes. That is one option that you actually can have. And I got that document right here that discusses the different things that you want to take into account. But we don't have a standard practice or guideline to the best of my knowledge. And I would be open to being educated if that's not the case. The problem is that as our residents age with dementia, and especially since the coronavirus pandemic, we have seen the increase focus on sterility and safety and loss of human contact. But as a result, that has led some of our more severe dementia patients to go without human touch for periods of months, except for basic cleaning. Because our patients with dementia do have difficulty communicating their needs, it is unlikely that they will be able to express them in a socially acceptable manner. And so now we have to have the discussion of how can we help provide the need for human contact and intimacy to those who have severe dementia, because on the one hand, it is not fair to deprive them of that. But on the other hand, it is not necessarily safe or fair for us to find a way to provide it for them. Often these people have guardians, and these guardians are often family members, children, and also it's an uncomfortable discussion for them to have. If someone who's been married to their partner for 45 years and that partner is deceased, seeing their parent with dementia engage in sexually inappropriate behaviors or possibly appropriate behaviors still may not be tolerable or really comfortable for them. So how do we have that conversation with them? So we need to understand furthermore what would be the baseline capacity of consent, and then how we can help support people with these needs. And this is less a recommendation of what to do, but more a call to action of where we can discuss this, because this would be, I think, an interesting topic within forensic and geriatric psychiatry and medicine. So I think that having this discussion is quite important. Does anyone have thoughts about this or personal experiences when they were, or not personal experiences, but experiences when consulting with a nursing home or a care home or foster home that they'd want to discuss about this?
No, I don't know. I'm just thinking, what are we going to do with this woman? And I'm thinking that maybe she's bored, and we really need to just keep her occupied with activities, and then just maybe give more like, sensory stimulation type of activities, like what we call here, like namaste program. Like we could have like hand lotion, gentle massage, listening to music and things like that. Just, and then maybe something to hold, soft plush animal or something like that, or something to squeeze in her hands, just to have some sensory stimulation of some kind. That's kind of what I would say.
I think sensory stimulation, that's all really, really good options. And it's also difficult because what you're doing is we also have to find and navigate to give somebody a patient right to intimacy and human kindness and touch without infringing upon the rights of the providers to have that expectation of them to provide it for her, right? So I remember I had a patient who was cognitively intact, whose husband had passed away. And her response to me was, this was a consult to her house. It was a follow-up appointment. And her response was, I miss being cuddled. She says, it's not a sexual thing, but I miss being cuddled. And I have nobody to cuddle with anymore. Well, it's not really upon nursing staff or recreational therapy to cuddle our patients, nor is it necessarily appropriate for them to do so. So how do we do that. And I think the option of providing, soft things is a step in the right direction. And I think it's something should be elaborated further. In the case of Miss Sally, redirection, safe outlets, like you had mentioned, and if patients want to be sexual in the privacy of their own bedroom, they're more than welcome to do that, provided they've got that privacy. In more extreme circumstances, SSRIs have been used off-label to reduce libido, as it is one of their more common side effects. And in males, in extreme circumstances, we've used conjugated estrogen. But this is, in no doubt, chemical castration, and it's only to be used in the most extreme cases when necessary. So in conclusion, there's a tremendous need for psychiatric consultation in the spectrum of long-term care. Often, many of these long-term care locations are under, or skilled nursing facilities, are under significant pressure from the CMS to reduce the use of all psychoactive agents, but in particular antipsychotics, as this will affect their quality and star ratings, which will lead, and while born out of an important need, may be now at a point where it causes us to take patients off of a regimen that they have been stable on their entire life. Psychiatrists play an important role in the diagnosis and treatment of mental orders in long-term care, thereby improving the quality of life of patients and their professional caregivers. We can also serve as educators in long-term care and mentors for optimizing treatment of psychiatric issues in the long-term care environment. I want to thank you to everyone, especially my parents, my children, my wife, my grandparents who showed me the beauty in aging and how to find happiness, even with physical and cognitive decline, and my mentors throughout. And I just always want to make sure that I give the kudos to those who required it. And especially all my colleagues, especially on the geriatric medicine team, who have been helping me in my education here while I've been in Hawaii. So thank you, everyone. Does anyone have any questions?
Noam, thank you so much for an excellent presentation. And I loved how interactive it was, and I loved the case discussions as well. Does anybody from our audience have any questions? I know we did a lot of discussion as we went along, but any residual questions?
I don't know. I was wondering, are you going to be doing nursing home consults?
I would love to do nursing home consults. As of this time, I'm not allowed to, I think, from a contractual purpose, but it's always a discussion to be had.
That's great to hear. We have a very large nursing home practice with the Queen's University Medical Group, and there are other practices out there as well. So the need is great. It would be wonderful if we could work something out.
You guys have my number. Any other questions?
Okay, I want to give a final reminder to everyone. The CME link is in the chat box from Michaela. So please remember, if you want to get CMEs, you do need to do an evaluation. So please complete the evaluation. And again, I wanted to thank Dr. Grysman for a wonderful presentation. We would love to have you back again.
Thank you.
Sometime.
Thank you so much.
Okay.